Welcome back to Girls Gone Wellness, Dr. Alpert.
Thank you so much. I'm so happy to be here.
Yeah, we're so excited to have you back. I can't believe it's almost been, I don't even know how many months now, like 10 months. It's been
Close to a
a
year.
wild ride, but we're happy to have you back. Obviously, you've been here before and our audience knows you, but in case they haven't listened to your first episode yet, could you just introduce yourself to our audience?
Sure. So I'm Dr. Laurie Alpert, naturopathic doctor and Menopause Society certified practitioner. And my practice focuses on supporting individuals through navigating perimenopause with more confidence, clarity, comfort, and choice. And so I was here before talking about mental health and perimenopause. And today we're going to talk about sleep and perimenopause, and they are so closely related.
Hmm.
So that's where I'm at right now.
Yeah, I was gonna say the mental health piece. I mean, if you think about it, if you're not sleeping, how much is that impacting your mental health? And then how much is your mental health, like anxiety and all of those kind of pictures affecting your sleep, right?
Exactly,
So,
exactly. They're
yeah,
closely intertwined. It's part of how, I'm showing up in this space because the interest in
yeah.
mental health that you can't extract the element or the value of sleep in that conversation.
Definitely. Now, is that kind of what drew you to this like more focus you're putting on sleep? Are you seeing it a lot in patients? Is that kind of what's happening?
Oh yeah, absolutely. When you think about perimenopause, the most common complaints and concerns, we assume it's hot flashes or night sweats or what we
Yeah.
call vasomotor symptoms, but a lot of the time what drives people to get help is their lack of sleep or their mood
Mm-hmm.
changes. And we often don't necessarily identify that as something that's perimenopause related, but
Yeah.
it's the three main pockets that show up in my office, and there's a whole bunch of other things as well, but yeah, and the
Mm-hmm.
reason I've decided to speak more about sleep is because I think A, people don't know that there's a hormonal component, and
Mm-hmm.
B, it's foundational. So if we can help people sleep better, then it makes all the other things better and easier. So it can improve mood, it can improve libido, it can help with weight management, it can help with so many things that
Yeah.
people are concerned with. So that's why I wanted to kind of put it on stage to say,
Mm-hmm.
"Okay, everyone, let's get you sleeping."
100%. I had a patient this past year in clinic who she told me, she said, Victoria, I feel like I'm going insane. Like, I
Mm,
actually feel like if I don't have a good sleep soon, like, I'm going to go crazy.
yeah,
And
yeah,
it's horrifying that like so many women are going through this and they feel like they often don't even know that it could be related to their hormones and this kind of change that's happening in their lives. So I'm so glad that we're talking about it.
mhm.
Um, Tell us what is actually happening hormonally in perimenopause that could be affecting our sleep.
So, it's a bit of a loaded question because there's a lot happening. We do see that there's, impacts from just the fluctuations in hormones that's happening through this time. So in perimenopause, we start to see a decline of ovarian production of hormones like estrogen and progesterone. It's not a nice, smooth, steady line decline. It's more of like you get spurts and fits being produced and spat out by your ovaries. So sometimes it's lower, sometimes it's higher, but it's very irregular and erratic. We have seen in the research, and we do know that there's a strong relationship between these hormones and sleep. The specifics of it are still being explored and evaluated, but we know that there are estrogen and progesterone receptors on several of our sleep wake like centers in different parts of our brain. So right there's a direct connection to our sleep
Mhm.
cycles. But beyond that, all of the symptoms and some of the experiences that happen with these fluctuating symptoms can also impact our sleep. So it might be a step removed, but for example, if you are having night sweats, you're going to wake up in a sweat
Yeah.
and it's going to be hard to fall back asleep. We also see things like increased rates of sleep apnea or sleep disordered breathing that can be associated partly in part to some of these changes in hormones, and even changes to our urinary patterns and having to get up and go to the bathroom more often in the night. So there's and then we can layer on like anxiety or daytime stressors, different things that are going to impact sleep. So it's not a simple answer, but
Mhm.
there's a lot of ways, both directly and indirectly, that these hormonal fluctuations during this life stage can really kind of wreak havoc on our typical sleep patterns.
Mhm. And I mean, like, it makes sense that hormones do play a role in sleep because I know people, even just younger people that have like a regular menstrual cycle, they'll say like, oh, during one phase of my cycle, like I can sleep better and some I can't. So like it does make sense that hormones do play a role at some point. And then when we get to perimenopause and we're on this like roller coaster, it makes sense that it would be even more heightened, right?
Yeah, and it's interesting because they have done research looking at like sex comparisons. So if we use the language men and women to refer to the sex assigned at birth with no assumption of gender identity here, we've seen that men and women's sleep architecture is the same until puberty. And then women's sleep architecture changes until postmenopause. And then they're
Mhm.
more similar again. So there's a very
Hmm.
clear relationship.
Mm.
And what you said, Jeanette, I find interesting because a lot of people don't recognize that connection, that they might not sleep as well in a certain phase of their cycle. So maybe in our world, we're often saying, track your cycle, track your
Mm.
cycle. We know how valuable that
Yeah.
is, like outside of
Mhm.
fertility concerns. So we're maybe highlighting that for people. But a lot of my patients, if I probe and ask, have you noticed, does this happen, consistently, or is it cyclical? And have you ever noticed if it happens in that week before your period? Or a lot of the time they're like, I haven't thought about it. I'll have to watch. So it's
Mm.
it's great if you're ahead of the game and you've already made that connection. It can make it easier to spot when hormones are truly, playing a strong role.
Yeah. Okay. Cool. In addition to hormone changes, is there a role of like cortisol? We hear a lot, blood sugar changes happening here too, or is it exclusively due to just like these sex hormone shifts?
Great question. And as you know well, it's often all connected and more complex than we'd like to imagine.
Mhm.
So the answer is yes. I guess that it's related to all of the things. There is a connection as well with some cortisol fluctuations and changes through perimenopause. Again, the specifics of that are still being explored and we're trying to understand it. There's probably a bit of a bidirectional relationship there. So, meaning the sex hormones can impact the cortisol, but also cortisol fluctuations can impact our sex hormones. And so it's sometimes hard to tease out. But with respect to cortisol, we do see estrogen does play a little bit of a role in regulating it. So as those levels go down, we might see peaks and valleys shift a little bit. So like that classic 3 a.m. wake up could
Mhm.
be your cortisol starting to go up a little bit
Mm.
earlier than it should, and it can make it harder to fall back asleep.
Mhm. And it's that whole like wired but tired situation like is that
Mm.
what's going on here?
Kind of. I mean, you can have that outside of perimenopause too, the
Yeah.
wired but tired, but it certainly
Mhm.
does feel like that to those of us who aren't sleeping in the middle of the night. It's like I'm
Yeah.
so tired, but I
Yeah.
might not even sometimes people's mind will start to get active, and that's where it's
Mhm.
like, I'm wired, I'm wide awake. Sometimes people will feel like I have a colleague who said she feels like she's plugged in. Like it's just like,
Mm.
oh, the electricity is now flowing at this time of
Oh.
night. So and sometimes that's when the anxiety can start to peak, and
Mhm.
you almost have what I like to call like a hot flash of the nervous system. So you might not wake
Mm.
up hot, but
Yeah.
it's sort of like a zzz, okay.
A buzz.
Yeah, exactly. And then it's definitely harder to fall back asleep like that.
Hmm.
Mhm. For
Yeah.
sure.
Yeah.
You briefly mentioned sleep apnea and sleep
Mhm.
disordered breathing. Is there
Mhm.
higher rates of this at this time of our lives? Like, do we see this show up more in perimenopause? Is that something that's also happening?
Absolutely. It's
Mhm.
more probably apparent post menopause. So in the earlier perimenopause phase, we might not see as much of that shift. But yes, rates of sleep apnea, we used to think were much higher in men, but it turns out post menopause, again, the rates kind of converge and become
Mhm.
more equivalent. So making that connection to what's going on, how are those hormones protective of something like sleep apnea? And
Mhm.
similarly to how we know there's receptors on the sleep wake cycles of our brain, there's also receptors for hormones on, all of our tissues all over. And so we're going to see an impact. And sometimes that shows up as a change in the the relaxation of some of the muscles around our tongue and our throat, which can contribute to some of this disordered breathing. There's
Mhm.
also, you mentioned before, we didn't get into yet, but metabolic changes. So if there's additional
Yeah.
weight gain, especially, in the core and the chest, and the upper part of the body, then that can contribute to some sleep disordered breathing. So there's
Mhm.
there is an increased risk of it, and
Mhm.
historically, underassessed, undersupported.
Yeah.
And so I think hopefully there's a shift now to call it out, make sure we're addressing these things for
Mhm.
women. The
Yeah.
other interesting thing I found in the research on this, though, is that sleep apnea presents differently sometimes in women. So
Mhm.
Yeah.
I tend to think of like an overweight man who's snoring, sleep
Yeah.
apnea, right?
Yeah.
But
Yeah.
you can have someone who's not necessarily overweight and not necessarily snoring, and they're still experiencing some level of apnea. And we see even those levels of hypoxia, it might be even measured a little bit differently, so on a lower scale, and not even caught on some of the traditional screening tools in the same
Mm.
way. So
Okay.
it's still a place for evolving research and medicine to go. But first of all, we should
Mhm.
be screening more.
Yeah. We talked to Dr. Leah Saunders
Mm,
about this, and she had mentioned that same thing. Like, you have
mm,
patients who you say sleep apnea, and they're like, yeah, right. Like, I definitely don't have that, and then
totally.
they end up having it. And it's like,
Yeah.
that's the fix you needed, right?
Yeah.
And
Mhm.
it's true. There's such a stigma there about
Yeah.
like this is what it looks like to have sleep apnea that I'm sure it's going very underdiagnosed,
Yeah.
right?
And this is a bit of a sidebar, but I did have a patient
Yeah.
recently, and she's very fit, mid 50s, diagnosed ADHD later in life. So in
Yep.
her early 50s. And as part of some screening, she doesn't snore, but I forget exactly what prompted the screening. But we did do a polysomnography, so sleep study, and
Yeah.
turns out she had moderate sleep apnea, and her mind was blown. She was like,
Yeah.
I didn't even know, right, that could be going
Mhm.
on underneath. My husband snores. He's got a CPAP machine. I never thought it could be me. And I'm curious, and this is totally out there, but I am curious if in like 50 years we're going to see any connection between sleep disordered breathing and some cognitive changes or like ADHD
Yeah.
type symptoms.
Mm. Yeah.
That's
Mhm.
just a thought out
Also, I
there.
think it's like such true love to like both have your CPAP machines beside each other at night. Like, how cute is that?
I love that you see it that way, because so many of my patients think, like, they'll avoid screening because they just don't want a CPAP.
Yeah.
And well, I think
Yeah.
it's important to highlight, though, that CPAP's not always the answer. There are other
Right.
types of sleep disordered breathing with different types of interventions and therapies
Hmm.
that can also be helpful. So
Right.
not
Okay.
always gonna lead to a
That's good to
CPAP.
know. So last time we had you on the pod, we talked about mood and mental health, and we know how important sleep is for a healthy mood. Is there a role, and what is the role of anxiety, depression, rage? Not just as a result of poor sleep, but also maybe as a driver of poor sleep.
Yeah, great question. So it's like we said before, we've known for a long time that there's a bidirectional relationship with mental health disorders and sleep quality. So if you experience or suffer from any mental health disturbances, you're more likely to experience insomnia.
Hmm.
Vice versa, if you experience insomnia, you're more likely to experience some mental health disturbances. So they're really closely linked. Sometimes it's a chicken or an egg kind of thing. And I
Hmm.
think it's up to, the clinician to really ask appropriate questions and find out what's going on here. The other thing to keep in mind, though, through perimenopause is that it's very well established now that mood disorders increase or worsen through perimenopause. So, not to be all doom and gloom, it doesn't happen to everyone, but there can be changes, and there can be worsening of pre-existing mood disturbances or mental illness. So highlighting that or having an understanding of that, so that as a clinician or someone who's supporting these patients, that's going to help in your decision making as far as what tools you're going to use to help someone sleep or help someone with their insomnia. Yeah, but
Mhm.
it is very closely connected.
Mhm. For sure. I'm glad that we talked about that because there is such a huge connection there. And I'm sure it just goes deeper than just giving someone, you know, a supplement that can help with their anxiety and their sleep and things like that. Like there is a lot that goes into helping those different things, like the internet would like us to believe.
Yes.
How early can sleep changes start before someone even realizes that maybe it's related to perimenopause or these like hormone fluctuations? Like, I'm wondering if someone who, say, a woman that's younger, like in their 20s or 30s, they've always had issues like falling asleep or staying asleep. Like, are they more prone to having these changes when they're getting into this like perimenopause state? Do you realize that or do you find that?
Yeah, great question. It's probably harder for people who have had trouble sleeping their whole lives to identify the role that hormones might be playing
Right.
because it can be subtle. Whereas people who haven't and they've always been great sleepers, then all of the sudden they're waking up in the middle of the night, they can't fall back asleep, or they're waking up at 5 a.m. and starting their day. Those are the people who come in and be like, I used to be a champion sleeper. I don't know what's happening.
Mm,
So, how early can it happen? It as you pointed out, we can see these fluctuations even through regular menstrual cycles in the premenopausal
right.
period. So it's just I think some people are more susceptible to it.
Mhm.
And I mean, maybe we'll get to this, but when I am approaching someone in perimenopause with sleep concerns, I'm thinking about sort of three pillars and where they overlap. So I'm thinking about the hormonal piece, like we've discussed. I'm thinking about like good old fashioned understanding of insomnia and chronic insomnia and sleep science and sleep medicine. And then I'm overlaying the third piece, which is some of the changes we see with aging. So if someone's younger and they're having sleep disturbances, then maybe the aging piece holds less weight, right? And maybe they're still cycling regularly, and perhaps those traditional sleep strategies are going to be more important,
Mhm.
but there may also still be a hormonal element. It's difficult to say. So I don't think there's like a set time. And especially because perimenopause and how people experience it is so varied,
Yeah.
uh, that it's person to person. And that's where tracking your cycle, having an understanding
Mhm.
of, does your sleep disturbance happen all the time? Has it been since you were 12, or even younger, can
Mhm.
really help the clinician and the patient figure out what's the best approach.
Mhm. Definitely. Are there any specific patterns you see in terms of like sleep disruption? Is it more that people are waking up at 3 a.m., like they fall asleep no problem and then they're up and at that point they're just up? Or are people having a harder time falling asleep? Is there any patterns or is it just kind of like chaos at night?
Oh god, that sounds so awful. Yeah, I think it's like when it comes to really the hormonal piece, sort of if we were ever able to really isolate that, the pattern that I see is more that early waking up at 3 a.m. or
Mhm.
starting their day at 5 before their alarm. Um, but again, because people can have chronic insomnia concerns or other sleep disturbances, it's not uncommon to have patients who are having trouble falling asleep and staying asleep. Although when I'm thinking of just the hormonal piece, that piece, like it's someone who comes in, I have no problem falling asleep. I'm so tired. I'm
Mhm.
ready. I hit the pillow, or it's like within 20, 30 minutes, no problem after I read a little bit. And then I wake up and I look at the clock and it's maybe 1:30, or I wake up at,
Yeah.
it's 4:30 and I can't fall back asleep. And so I'm ready for the day. And then it's this cycle because then you're tired through the day and then you're
Mhm.
ready for bed at, 9 or maybe 10 and then fall asleep fine, but still waking up early. So it's a great question. And it's that we call it waking after sleep onset. So you've already fallen asleep, but you can't maintain that sleep in the same way.
Mhm.
Okay.
Yep.
Is that
Mhm.
what you see clinically? Do you see that in your
Yeah,
practice?
it's
Yeah.
Yeah.
it's always like just I'm up and then that's it. Like there's
Yeah.
just no going back to bed at that point.
Mm.
Um i- do you ever suggest tracking sleep? I feel like I see it like being a good thing and a bad thing. I know my
Mm.
own mom like every single morning is like I only had 27 minutes of deep sleep, Victoria.
She's looking at our device. Yeah,
Yeah.
better app.
Yeah, do you ever suggest those or is that just too much?
It depends on the person and it depends
Okay.
on the type of sleep disturbance. For me and how I work.
Yeah.
So first of all, the digital trackers sometimes are helpful and sometimes can be harmful. So just kind of bringing up questions about the accuracy of them. They're not always
Yeah.
that accurate.
Mhm.
And what kind of information are we gleaning from it? And is that helpful to us? Like, is it going to actually help us change our behaviors, or is it going
Yeah.
to help us understand something that we don't already know? Like, you wake up tired and you know you're tired. Do you need this to tell you you didn't, your sleep
Yeah.
quality score? Like,
Mhm.
you can give yourself
Yeah.
your own score.
Mhm.
Um, so first, just questioning, is this a useful tool or not? And for some people it might be, because it says, oh, I was really consistent with when I went to bed and when I got out of bed, or like, those several weeks I was all over the place. I stayed up
Yeah.
later and whatever. Um,
Mhm.
but so the other tracking that comes up a lot is like almost worksheet tracking, honestly, where I'm using it as part of a like CBTI approach, so
Mm.
cognitive behavioral therapy for insomnia. So it's not so much the tracking you would have with a device, but kind of like, what time are you getting into bed? What time do you think you're falling asleep? What time are you
Mhm.
waking up in the night? How long are you awake? Or, what time do you get out of bed in the morning? Um, to kind of distinguish how much time are you spending in bed and how much time are you actually sleeping while you're in bed, because that's
Mhm.
going to drive some of the therapies, actually.
Yeah, I'm glad that we talked about that. There's definitely pros and cons, and it's definitely individualized approach for sure.
Mhm.
I
Mhm.
know for me, like that would give me so much anxiety if I like saw all of that stuff, and I would get
Exactly.
so obsessed, and it would make my stress so much worse. But for some
Exactly.
people, it's like very helpful for them. I have friends that they've really like improved their sleep because they're motivated by like those
Yeah.
scores, I guess in a different way. For me,
Mhm.
it would be the opposite, but
Mhm.
yeah, to each their own.
Yeah, and you got to know yourself that way. I think that's great.
Yeah, yeah.
Mhm.
I'd love to jump into the role of hormone therapy because, of course, this is a big conversation online and just in general as well.
Mhm.
So, what is the role of hormone therapy for sleep at this stage in life? Can you use it primarily for sleep? Are you using it for other symptoms? And the sleep is kind of just like a side benefit of hormone therapy. I'd love for you to kind of go through
Sure.
this whole piece.
So, according to guidelines and standards of care, it would be an off label use. It's not approved for sleep disturbances on its own. Um, it is approved for vasomotor symptoms. So, if someone's having sleep disturbances as a result of night sweats, then it's a no brainer, right? We're going to
Mhm.
resolve the night for people where hormone therapy is appropriate, of course. So, then you're going to have that conversation, and we want to resolve the night sweats, and that's going to help people sleep through the night. And then they get the added benefits that we see from hormone therapy that are independent of hot flashes. So I think what's less understood is that other piece where they've done studies. They had people do these sleep studies. They went into the lab, they had all the electrodes on them, and they even measured like thermoregulatory measurements to see what their actual body temperature was. And then the patients would wake up and they would kind of report their own subjective experience of both their sleep and any vasomotor symptoms. And they saw, confirmed both with the subjective experience and the objective markers, that hormones, because they were also checking blood levels along the way, hormones were only associated with like, and hot flashes or night sweats were only associated with 1/3 of the wakings that were reported.
Mm.
So we assume, oh, I'm just waking up because of this hot flash, right? But actually, there's a lot more sleep disruptions that are happening that aren't tied to the hot flashes. So to answer your question, we would use systemic hormone therapy to resolve hot flashes or night sweats. That's on label standard of care. If
Mhm.
someone is coming up and they are waking up in the night, they're following that perimenopausal sleep disruption pattern. They're clearly in perimenopause, but maybe not having any vasomotor symptoms, then I think it's certainly worth exploring. However, with clarity and understanding that it's off label. It's
Mhm.
not an approved indication for it in that case.
Right, okay. So it's not just as easy as taking progesterone and fixing your sleep. It's not just as
Yeah,
simple as that.
I mean, for some people it is.
Okay, okay.
Yeah.
Quite honestly, for some people, it's like, great, that's the game changer.
Okay.
Mhm.
But that's probably the minority, because
Mhm.
usually there's, like I said, there's the hormonal piece, but then there's the classic stuff that's contributing to
Right.
insomnia, whether it's behavioral or what have you, that also needs to be addressed.
Okay.
Hmm. Now, progesterone on its own has like a sedative effect, right? So could that just be it too, that it's like calming and from that angle that it's helping people?
Totally, totally. It
Hmm.
can help for and it has been studied and shown to help with sleep and also mild vasomotor symptoms. So
Hmm.
it can work on both levels when it's like earlier. And progesterone, it is sedating, and we think that might have to do with how we have those receptors on those sleep wake centers in our brain, right?
Yeah.
So it works
Hmm.
that way too. And
Yeah.
it's definitely a very helpful option for some people.
Okay.
It makes sense. Now,
Mhm.
a question I hear a lot, I think a lot of women wonder this. Can you start hormonal replacement therapy in perimenopause? Because I think there is an assumption that you start hormone replacement therapy once you are fully in menopause, right? Once you've hit that 1 year, no cycle, then you can start hormones. Um, is it safe to do that in perimenopause? Does it look different? How do you have that conversation with patients?
That's a great question, and it is a myth that persists, and it's even something that some caregivers continue to tell, or health caregivers continue to tell their
Yeah.
patients. But no, you do not need to wait until you have reached menopause or past menopause. We see additional benefits and really strong safety profile for people using it through the perimenopausal transition.
Hmm.
So it's definitely worth a conversation when indicated.
Hmm. Okay.
How would it look different? You also
Mhm.
asked.
Yeah.
Um, so this is where there's a little bit of variation and sort of prescriber preference, and it might be subtle in what the person is experiencing, because some people may need that combined estrogen and progesterone therapy even early in perimenopause, and some people don't need quite as much support, and so progesterone only support can be used at the beginning.
Mhm. Mm.
We never use
Okay.
estrogen by itself because that
Yeah.
will increase risk of endometrial cancer, but progesterone by itself is okay. And
Mhm.
then
Mhm.
it may be dosed differently. So it may be dosed like in a cyclical pattern to try to mimic your natural cycle,
Mhm.
or it's going to be dosed daily. And to be honest, a lot of my patients, even if they try the cyclical pattern, or if they come to me and someone else has prescribed it in this cyclical manner, when they're getting benefits to sleep, they want it every day, right?
Right.
Right.
They don't want it only 2 weeks or 12 days of the month. So sometimes
Mhm.
and it's okay to do it, straight as well during perimenopause.
Okay.
Mhm. To confirm, this is oral progesterone, not progesterone cream,
Correct. Yeah, I'm
right?
so
Okay.
glad you confirmed that, because even there have been studies looking at different, like, vaginal applications, topical applications, oral applications, and even oral micronized progesterone compared to different progestins.
Yeah.
And we do see that the oral micronized progesterone is the one associated with the best sleep outcomes. So you're not going to get the
Okay.
sleep benefit if you do a cream or even a vaginal suppository.
Okay.
Okay. Okay. Makes sense.
Mhm.
Okay. So, you know how they say that when you are in like perimenopause and as you get older, you need more protein?
What? You've
I
heard
w-
that?
Does the same apply for sleep? Do you need more sleep at this stage of life? And is that why, like, for people who maybe they feel like they are getting that 6, 7 hours of sleep, but they're still kind of exhausted? Do we need
Mhm.
more sleep in perimenopause, or is it about the same?
It's such a good question, and I think what we have is data of observational data of,
Hmm.
millions of people and their sleep cycles and sleep architecture, and what we see actually is that our window of sleep shortens over
Hmm.
time, like, kind of from when we're young to when we're middle-aged, and then it sort of plateaus and then maybe goes down again as we get even older in our late 70s maybe.
Okay.
And the type of sleep we experience through those years also changes. So it feels different. So it's not that we're
Hmm.
sleeping less, but we're maybe spending more time in that lighter stage of sleep. We're more
Yeah.
easily aroused, that kind of
Hmm.
thing.
Yep.
But it's not like, oh, I like a teenager who they really need
Yeah.
to be
They
having
need more.
more
Yeah.
sleep. Yeah,
Mhm.
Okay.
exactly. Yeah, but
Okay.
I think you brought up a good point too, though, because sometimes people will say, I'm sleeping, I go to bed at 11, I get up at 7, and I'm not
Hmm.
waking up in the night, or if I wake up, I fall right back asleep and I'm still so tired. There
Yeah.
are so many causes of fatigue, as you know,
Yeah.
but that's one of the things that raises my flag, or raises a flag to screen for sleep apnea. Because if someone is getting
Hmm.
sufficient sleep and we've resolved all, nutrition, iron deficiency, all those things, thyroid, we're looking at all that. But they're still tired. It's like, well, maybe you're just not oxygenating throughout the night.
Right.
Mhm.
Yeah.
Yep. Definitely important. What
Mhm.
other lifestyle contributors are messing up our sleep? We hear a lot about obviously like alcohol, caffeine, screens. Should we be avoiding these as well as that in this point of life, or are these like also making it worse at this point in life? What do you see?
Yeah, I mean, we know that alcohol, caffeine, and screens are not going to help sleep at any stage of life. But the difference at this stage of life is that at least alcohol and caffeine, it has been shown in some people to worsen those vasomotor symptoms and
Mm-hmm.
potentially worsen anxiety. So those are both things that are going to also worsen sleep. So
Mm,
our sensitivity to that can increase through perimenopause. And I'll have a lot of patients who sort of like, self adjust and they say, you know what, I just can't drink anymore. Like I'd love to,
Mm-hmm.
but I it messes with my sleep so much. It's so obvious to them the impact it has on their sleep in a way that it didn't when they were younger. Yeah. And then what was the other one? You said alcohol, caffeine, and
just screens like
oh,
blue light, I guess. Yeah.
yeah, that's a whole thing, right? At screens. We don't have any research of screens on pretty much people over 25 or 30 years old. Like all the research is on adolescents or young adults. So we can extrapolate. I don't know, but in what I've seen clinically, there's not a huge difference. There might be a difference in how we use screens as like middle-aged women, scrolling through social media at night in bed. Although teenagers, I'm sure, do that too. So I think my approach is most likely the same kind of understanding of the impact of screens that we have from younger adults is still applicable in many.
Yeah. It's interesting when I've talked to patients at this point in life too, where they've said the same thing that you mentioned. Like, I used to be able to drink like 3 cups of coffee, and now if I have coffee past 1 p.m., like it messes up with my sleep. And before I could drink coffee right before bed, or like same with alcohol. So, like, it is interesting that I don't know if it's your tolerance or like hormones as well. Like, something there is definitely playing a role, for sure.
Absolutely. Well, we feel a lot of the things that are happening with some of the fluctuations can leave people feeling just less resilient in general. So it's
Mm,
like things that we used to be able to get away with, we just can't get away with in the same way anymore. And that's what's really challenging for
right.
people.
For sure. You talked about this on your Instagram that sometimes sleep hygiene is just simply not enough.
Mhm.
So, what would you say is the role of sleep hygiene in getting women to have a better sleep? Is there a role here, or again, like, is it much more complicated than just saying, okay, like 30 minutes before bed, turn off your screens, have a shower, like all of these things that we tell younger women?
Yeah, well, sleep hygiene is always important. It's always
Mm-hmm.
going to be like a pinnacle of sleep therapy, right?
Mhm.
Because we know how what an impact it can have, and we know that it can also have an impact in someone in perimenopause. I think what I wanted to call out with that post was just we also should be thinking about hormones in this population and not be scared to approach it from this lens because
Right.
somebody can be doing all the sleep hygiene things. Like they can be killing it from a sleep hygiene
Mm-hmm.
perspective and still waking up. And that's
Yeah.
usually where the hormones are needed.
Mm-hmm. It's funny because so again, I always bring up my mom, my poor mom. But she
You should have your mom on the show.
to get her to sleep, like I've said, maybe try like a brain dump, like before you go to bed, just write everything down. And
Yeah.
she's like, it makes it worse. Like now I'm like, oh my gosh, I have all this stuff to think about. Like my sleep hygiene is making it worse.
Yeah, well, that's where CBTI plays a role too, and I think a lot of
Yeah.
people assume CBTI is like sleep hygiene and maybe sleep restriction, or it's
Right.
just maybe people think sleep CBTI is sleep hygiene, or
Mm-hmm.
people have never heard of CBTI. So for the record, CBTI is cognitive behavioral therapy
Yeah.
specifically for insomnia. It's very well evidenced. It is first line and recommended in all guidelines, all standards of care for pretty much most sleep disorders
Yeah.
because it's, very like no side effects.
Mm-hmm.
Access can be an issue because it's better done with a therapist with where you meet with on a weekly basis for about 8 weeks.
Mm-hmm.
But a lot of people don't know about it. And for example, I had a patient recently and she's been having chronic insomnia for the last like 3 years, and she's younger, maybe late 30s. So, no one was thinking hormones for her.
Yeah.
But she had tried antidepressants, she tried sleep pharmacology, she tried supplements, she'd been doing her sleep hygiene. And no one in the years that she'd experienced this had even mentioned CBTI. So when I talked to her about it, it was a brand new concept, right? So I still
Wow.
think it's something that's like, it's so strongly indicated and like really easy to think about and access, and like no side effects, but
Yeah.
it takes some time and some work. So it's,
Yeah.
just our approach to care is often like we want a pill to fix it fast,
Yes.
and
That's
especially
exactly it.
Mhm.
Mhm. Yeah, we all want just, like, kind of like that immediate gratification, right?
yeah.
Which I
Yeah,
get, like, we wanna sleep, we just want it to happen tonight, right?
exactly, exactly, and so, I mean, maybe we'll get to this too, but there is a role sometimes for that pill that's just gonna help you right
Yeah,
now, and then you can use that
100%.
as, like, a bridge to implement the CBTI or the sleep hygiene and that kind of thing.
Yeah, and it's so funny because there's such a stigma with using pharmaceuticals.
Yeah.
However, it's like, do we know the impact of not sleeping on your health?
Yeah.
Like, if we wanna talk about the
You
impact of a
do.
pill, I mean, come
Right.
on, right? Like,
I
sleep is
know.
foundational.
It's
Mhm.
that
Well,
conversation. I was just saying this
yeah.
to someone yesterday. It's the idea of like we often thinking, and I'm sure you've heard this from lots of your people on here, but like we're often thinking about, the cost of doing something, what are the side
Mhm.
effects or what have you, and we're not thinking about the cost of not taking action or not doing
Yeah.
something
Yeah.
we're
Mhm.
left with. Yeah.
So true.
Yeah.
You mentioned briefly sleep restriction. Can we touch on
Yeah.
that quickly? What is sleep restriction?
So, sleep restriction, it's based on the concept of sleep efficiency. So, sleep efficiency is the idea that we should be sleeping for a certain percentage of time that we're spending in bed. Because we do have in some of the behavioral science and sleep science and neuroscience, there's a clear connection, like an association of bed with sleep, and we want to
Yeah.
strengthen that association of bed with sleep in our sort of unconscious and conscious brains. So if we see that someone is, for example, spending 10 hours in bed because they're going to bed at 9 and they're waking up at 7 for work, but they're
Mhm.
actually like awake a lot in the night. So they're going to bed early at 9 because they're so tired, and they're staying in bed till 7 because they haven't slept well and they want to get the most out of their time in bed. That's 10
Mhm.
hours in bed, but maybe they're only actually sleeping 6 hours. That's a 60% sleep efficiency.
Mm.
And so the ideal is about 85 to 90%. So in some cases, and I wouldn't recommend doing this without consulting a care provider to help you figure out if this is appropriate for you, or because there are some cases where it's not appropriate to do.
Mhm.
But you would then look at either shrinking the window you have in bed, which is sleep compression, or sleep restriction as we limit the time we're in bed to build sleep pressure throughout the day. And
Mhm.
then so that when we get into bed, we're tired, we fall asleep, and we stay asleep for the time we're there for a better sleep efficiency. But it requires you
Right.
to actually like get yourself out of bed at a certain time and not get into bed until a certain time
Mm.
and not nap before you get into bed at a certain
Mhm.
time.
Right.
So it's short-term pain for long-term gain, but for some
Mhm.
people it just helps reset that circadian rhythm, and it's counterintuitive because people are tired, they want to spend more time in bed so they can like
Yeah.
maximize their opportunity to sleep.
Yeah,
Mhm.
That
yeah. I
part.
actually had a supervisor in clinic that really loved sleep restriction therapy and would have us recommend it to a lot of patients that were experiencing insomnia. And it was helpful for some of them. Like it was cool to see it, but it definitely is not an enjoyable process
I know.
for patients to go through.
I know. I warn people and I say short-term pain, long-term gain. It's gonna be hard. Trust me, like give me 2 weeks.
Yeah.
Yeah.
And do it at a time when, like, you can afford to be tired. You're already tired, but you know what I mean?
Mhm.
We pick our moments.
Yeah. Would the same thing go towards, like, say people are working from home and they're working on their laptop in bed, or like
Mm.
they're relaxing in bed and scrolling on their phone and things like that? Like doing things maybe like in bed that isn't like sleep. Would we also want to kind of limit that as well to help with like our sleep quality? Do you see that as
Yeah.
well?
Yeah, absolutely. And we call that stimulus control. And that's another part of CBTI where it's again reinforcing that message to strengthen the connection between, bed and sleep. So if we're doing
Mhm.
other things in bed that don't include sleep, then we're kind of weakening that association for ourselves. So I
Mhm.
Yeah.
find some people are really sensitive to that and some people can get away with it no problem. So
Mhm.
I see people and they'll post online and they're working in like their presentations in bed in their laptop
Yep.
and it's like 11 on a Sunday and I'm like, "No, I can't do
Yeah.
that."
Mhm.
But it doesn't bother everyone.
Right.
But yeah, it's a really good
Mhm.
point.
Mhm.
Yeah, definitely. I think nowadays too, like so many people have TVs in their bedrooms,
Yes.
right? And
Mhm.
so I try to tell patients, and I don't know if this is just like something we say and it's not backed by evidence, but I always tell patients like sleep and sex, like that's it in
Yeah.
bed. If you can do everything else, if you want to watch TV before bed, go to the living room,
Yeah. Yeah.
Mhm.
right?
It is
Just so that we don't get that
absolutely backed by
association.
evidence. Yeah, it
Yeah.
is.
Okay. Well,
And
that's good
and
to know.
yeah, it is. It's tricky though because there are patients where like their whole life they've fallen asleep to white noise of the TV in their room. And so
Yeah.
Right.
that there are people I can't get them to change that
Yeah.
and some people can still have success with,
Mhm.
getting better sleep without changing that and some people it's just like such a hard ingrained habit and I think
Mhm.
that's where CBTI can really change especially with the support of an appropriate therapist because
Yeah.
that's not an easy thing to shift but it might make a difference for those people.
Mhm.
Yeah.
Definitely. Walk us through what it looks like when you have a patient who comes in and they have just no idea what to do. They just want to get to bed at night. They're really, really struggling. You had mentioned the three pillars that you look at, but walk us
Mhm.
through what it looks like for a patient in their initial visit with you when they're struggling with sleep.
Yeah, great question. I mean, I think most people when they come to me, because it's clear that I work with perimenopausal women, that there is an element of hormonal concern as well. So their
Mhm.
main concern might be sleep, but they're usually in midlife, and it's like I don't know if hormones are playing a role or not, but that's why I'm here.
Mhm.
So we'll go through a thorough intake. Naturopathic intakes are very thorough,
Mhm.
and we'll talk about their main concerns. So I will screen for things like what are they doing before bed? What time are they getting into bed? How long does it take to fall asleep? Like, kind of to get an idea of is it hard to fall asleep? Is it that you're falling asleep fine and waking? So we go through the whole sleep evaluation.
Mhm.
Um, and then I will also do the kind of whole hormonal intake, like what's going on with your period? Are we having vasomotor symptoms? Mental health, like is there anxiety? So it's pulling from all of those things before I decide a plan, and
Mhm.
then we'll present some options and see where the patient wants to go from there. Because I think sometimes people have a sense and
Mhm.
they have an idea of what they think will help. Um, and sometimes they're like, I don't know what to do. I've tried everything. Help me.
Mhm.
Yeah, I'm sure you get the same thing.
Mhm.
Oh yeah.
Definitely. For
Mhm.
sure. I know we talked about sleep medications, pharmaceuticals, and their role. What is the role of these when someone is coming to you and they've had these challenges for, say, like a long time? Do you ever discuss these with your patients? When would
Mhm.
these be needed?
Mhm.
We also hear a lot, like, especially about like sleep medications, like, can these be used long term? Are they just for the short term? How do you kind of talk to your patients about this conversation?
Yeah, I think I have a mix. So there are some patients who come in, they're seeing a naturopathic doctor because they particularly don't want,
Mhm.
a pharmaceutical drug like a sleep aid to help them with their sleep. Or I have patients who come in and they say, I've tried all the things.
Mhm.
Or they come in and they say, I'm already using this. Like I'm on this already.
Yeah.
And I can't sleep without it. And I'm good with that, but like it's not working as well anymore. Or, eventually I'd like to come off of it. Sometimes is brought up. So I think sleep aids can be very helpful. I like to consider all the tools available to us, so if and when they're indicated, let's take advantage of it. It's knowing when to use it and how to use it. So you asked if they're safe. I think they are a lot safer than people probably think they
Mhm.
are because they have evolved. So we do
Yeah.
Mhm.
have a fair amount of options. We have different classes of sleep aids that aren't habit forming in the same way that they
Mhm.
used to be. We still do have those old habit forming drugs too. So knowing the difference and how long to use them for is helpful. But I think there are times too where I'll work with people and maybe we do the sleep hygiene or even the CBTI. Maybe we go through all the steps and then it gets to a point where I think it's time to consider, sleep meds. Um, and they're okay with that. And then the flip side is like, this is so severe. It's going to take you time to implement XYZ. We've already used, or maximized the benefits from hormone therapy.
Mhm.
So maybe it's time to consider this, like I said before, as like a bridge while we implement some of the other changes and just to get you the rest that you need in the meantime.
Mhm.
And some of the
Mhm.
research we have on them, of there's safety for using it up to 2 years. So I think the fear that comes is from some of the older products. So
Mhm.
just being open to those conversations is important.
Mhm.
I think we play such an important role in this by just having those open conversations because
Yeah,
I think medical doctors are like well intentioned, right? But they don't really have the time to sit down and be like, I think you might be thinking of like the old drugs and this is kind of more how this one works, and they don't have
totally.
the time, right? It's
I
like you're
know,
in, you're out, here's the pill, good luck. Where with
totally.
us, people are often kind of like, oh, you think this is okay?
I know.
And
I
all of a
know.
sudden, it's like the validation they needed, right? Just through us being able to have the time to have that conversation and really inform patients. So I think
A
that that's
hun-
really special.
a hundred
Mhm.
percent. 'Cause we have people come in, they're like, I have a script, but I haven't taken it yet because I'm scared. And so we talk about, okay, when is it appropriate and what are you scared
Mhm.
of and what are the outcomes and what are the costs of not doing anything,
Yeah.
all that
Yeah.
conversation. Yeah, I
It's
agree.
so true. It's so true. And I
Mhm.
think sometimes people come in and they're like, well, I have this script for a pharmaceutical, but instead I want to try a supplement. And I
Mhm.
try to have the conversation of like, I don't think that this is an alternative. I think that this is
Mhm.
another avenue we can explore. And if it
Mhm.
doesn't work, we can go back to this.
Yeah.
And on that conversation, what
Yeah.
do you think about supplements for sleep?
Yeah, I think supplements like pharmacotherapy can play a role.
Hmm.
I like to think of them as like the spice of the meal, though. They're
Yeah.
rarely like the main course. For some people, in certain cases, maybe they get everything they need from their like oral lavender, but it's quite rare,
Right.
especially in perimenopause, right? Like in perimenopause, when there's all these other things at play, I
Yeah.
will use them for people and I will use them even in the same way, like as that bridge, like let's give this a go and see what impact it has and help you just get a little bit more rest while we work through some of the other options. So there's a role, but it's true. We have to acknowledge that the research is potentially limited. The magnitude of
Hmm.
effect might be limited. Like it doesn't work the
Yeah.
same way as pharmacotherapy. So just informed consent and honest communication about what we expect from them, I think, is important.
Mhm.
Hmm.
What are your thoughts on melatonin for sleep?
Melatonin is great for sleep. It can do the job for some people. It depends. The
Hmm.
research is more it's great for jet lag, it's great for, shift
Yeah.
workers, and it's really strong for shifting that circadian rhythm in certain cases. Um, More evidence to help you initiate sleep. Some forms, like even, the sustained release, maybe help certain populations sustain some sleep. And for some people, it can be really helpful, but clinically, some people it's just not enough, right? So that's why we need to be thinking about all the options.
Hmm.
And interestingly, it has been studied to see if it by itself helps with menopausal symptoms, like
Yeah.
independent of its impact on sleep. Like, what impact does it have on hot flashes and mood disturbances and that kind of thing? And
Hmm.
it's like, meh, more research is needed, but it's
Hmm.
certainly not going to compete with our existing first line therapies at this stage.
Hmm. Yeah, definitely. What about, so when we have the conversation about exercise, we know that like regular activity can help promote better sleep. But I also wonder at what point do we realize like, okay, sleep is actually more important than me waking up at 5 a.m. and going to the gym, or
Mm.
by me working all day, being stressed, and then coming home and hitting the gym and then going to bed. You had a post that made me laugh. It was something about like the best exercise you can do sometimes is sleep,
Yeah,
right?
yeah.
So I wanted to talk about that because we know it's important, but at what cost, right?
Yeah, I don't think there's a hard line in the sand. I think
Yeah.
there's a conversation. I remember when I was in burnout and exhausted, and my husband was like, "You should exercise. It'll be good for you. It'll help with your mood. It'll give
Shut
you
up.
energy." And I was like, it was not the right tool at that time for me. Like, I
Yeah.
needed to do other things first.
Yeah,
You
for
know, it's
sure.
well intentioned. So it that's where I think a comprehensive and like sort of like whole picture approach is really helpful, because if you're so fatigued that, you know, it's like you said, exercise can make it worse.
Mhm.
You can just be burning out or like worsening that cortisol response to some degree. We know, generally speaking, exercise is great for sleep. It's
Yeah.
great for mental health, but the type and the timing probably make a difference too. So, you know, rigorous exercise right before bed, not likely to help you sleep. It's
Yeah.
recommended to do it earlier. The type is less relevant. Something you have to like listen to your body. Is this I like people showing up for exercise on a regular basis, even if they're at the point where all I can do is like walk
Yeah.
or you know, stretch. It's like great. We're gonna work towards something over time, but maybe they need, you know, some nutrition support. Maybe they need iron IV, right? Like maybe
Yeah.
there's some other things first. So it's a really good question that's
Mhm.
individualized again.
Mhm. Definitely. If someone could only change one thing starting tonight to support their sleep, what should it be?
I find this question really hard.
Had to throw
Like,
that one in
it's
there.
like, it depends.
Yeah.
I think it's to give it the attention it deserves. So
Mhm.
I think it would be like, oh, I actually need to prioritize this. So it's not going to be an immediate overnight necessarily. You know, we could talk about, okay, maybe get outside in the morning for your daytime exposure, or stop drinking coffee, or talk to a hormone specialist or whatever. Like there's so many things, but I think it's just what I would like people to do is um, not take sleep for granted. And if it's poor, uh, start to pay attention and, you know, ask for the help that you need. Does that
Mhm.
make sense?
Yeah,
It's
no,
probably
that's a
not
great
what you're
answer.
looking for, but
No, it's a great answer. It's so
Mhm.
important. I feel like people they take their sleep for granted.
yeah.
It's something we do take for granted for sure. Any other myths or misinformation out there about sleep and perimenopause that you wish more women understood?
Yeah, I think also that the trap we fall into is and it's not our fault, like we didn't know, is either we just didn't know that there was this connection, first of all.
Mhm.
But second of all, that how long it can last. So, you know, we might go through a couple nights of poor sleep, or it can evolve slowly, and then all of a sudden you're like, shit, I can't remember. I don't know. Sorry if I say
It's fair.
I can't remember the last time I slept through the night. And it
Yeah.
didn't start. It wasn't like one night it happened and you never slept through the night. It was like progressive and gradual. So suddenly we find
Mhm.
ourselves having a chronic sleep disorder that we didn't realize, how did we get here? So I
Mhm.
guess it's just paying attention, and you don't have to wait, you know, till you feel like garbage
Yeah.
to start making changes.
Mhm.
Definitely. It's so funny because women, like all through our lives, like we talked about how it can change with your cycle. And then when you have children, your sleep
Yes.
obviously changes and all the
Yes.
things. And often, like your husband is asleep within like 3 minutes beside you. And that's got to be frustrating.
And then snoring.
Yeah. You're like, really? um, I loved this conversation. I think it's really important to address these things. It's funny, I'm looking at our rapid fire right now, and we definitely hit all of these points, but let's drive them home anyway so that people really get a good summary. So you know the rules. I'm going to say a statement that is a common assumption, and you're going to say myth, truth, or it depends. Okay.
Okay.
Alrighty. The first one is high cortisol in perimenopause is the reason for a lack of sleep.
I guess it depends. I want to say
Yeah.
myth. It's so much more complex than that.
Yeah. Progesterone alone tends to solve sleep concerns in this phase of life.
Partly.
Okay.
I'm not good at this game.
Progesterone cream can be a helpful addition for insomnia in perimenopause.
Oh, false. Thank
People
you.
talk about like wild yam as well as
Yes.
being like
Yeah,
progestogenic.
yeah, like
Yeah.
diascoria. Yeah,
Yeah.
that yeah.
So
And I
same
think,
kind of
well, that
idea.
one, like, converts maybe, so I don't know. I don't know if there's any research on it for sleep, I'll be
Yeah.
honest.
Yeah. Sleep deprivation impacts blood sugar balance, which can affect mood and weight management as well.
Oh, yeah, truth.
Yeah. I think what's important here too is like sleep deprivation. I remember Dr. Saunders saying
Yes.
is like less than 7 hours, which is crazy.
Mhm.
Yeah, and the impact, like, the unconscious impact we don't even realize, but then we actually consume more calories in a day if we're sleep deprived.
Yeah.
hmm
Uh, and then so over time, like, the weight, so many women in perimenopause, like, "I haven't changed anything, but my weight's gaining," and there's lots of reasons for that too.
Yeah.
Um,
Yeah.
but when sleep disturbances are part of the picture, it just makes it worse.
Oh,
Mhm.
yeah. Absolutely. Risk for sleep apnea tends to go up in this phase of life.
True.
hmm
Fact.
Pharmaco Yeah. Yeah, true,
Sorry.
true. Pharmacotherapy is the only option for insomnia in perimenopause.
Myth. Great, you
Amazing. That
gave
was
me
a
some
good
easy
round.
ones. You gave me some good black and white ones, which is rare. Thank you.
Amazing. Okay, well, thank you so, so much again for coming on for the second time. This was such a good conversation. I know I was thinking before we had this that we've only ever had one other episode on sleep in our whole year of doing the
Oh,
podcast.
wow.
So I think
Yeah.
we need to talk about it a lot more. It's something that we say like is a pillar of health, but we don't talk about it as much as we should. So I'm really glad that we did have this conversation with you today. Thank you so much again.
Thank
Can you
you.
tell our listeners where they can find you, where they can book with you, and like any other fun projects you have coming up?
Yeah, thanks. So you can find me on my website, drlauriealpertnd.com. And also I'm on Instagram, so at drlauriealpertnd. I am also launching a course of perimenopause sleep solutions specifically for this to help people so that you can understand what's going on with your sleep. It's a DIY 8-week course, and it does guide you through some of those principles of CBTI. So you can get the behavioral support that you need with like accountability, activities, that kind of thing, but then also the education on what's specific to sleep disturbances in perimenopause so that you can identify some of these things for yourself and like know who to talk to about it if it's a concern. So I'm really excited about that. Yeah, so if you want, reach out through my website or Instagram and check out the course when you're ready.
Amazing. I'm very excited about that. Well,
Me
thank you
too.
so much again for coming on.
Thank you for having me. It's a pleasure.